Hello, this is the TCT at TCTAP session. I am Gary Mintz. My co-moderator is Marty Leon, and we are from the Cardiovascular Research Foundation in New York. Even though TCT in 2020 was virtual, the science continued to be excellent as in previous years. And we have invited 4 of our colleagues, leaders in their fields, to discuss the interesting science that was presented at TCT Connect 2020. The first presentation on endovascular intervention will be from Sahil Parikh. Sai, it's all yours.
Gary, thank you so much for a kind introduction. We were excited this year at TCT Connect to have outstanding data presentations from late-breaking clinical trials. My disclosures for the record. I wanted to emphasize that endovascular drug delivery is still a very hot topic in the field, and we had 4 presentations that were really important and worth highlighting. And I'll try to briefly go through these in the next few minutes. The Voyager PAD mortality analysis and the Illuminate global registry analysis were important presentations in the field documenting the risk and benefit of paclitaxel-coated products for the treatment of femoral popliteal disease. Where we are still struggling in the field is in the below-knee treatment for critical limb ischemic patients. And there were 2 important studies that were presented, the IMPACT below-the-knee randomized trial and the TANGO periadventitial delivery trial of temsirolimus for inhibition of intimal hyperplasia. We did have a couple of other presentations, which I won't go into today, but I think we'll focus on drug delivery. First presentation was by Connie Hess from the University of Colorado at Denver, talking about long-term safety of drug-coated devices for peripheral artery revascularization from the Voyager PAD clinical trial. As many would know, the controversy around paclitaxel has been a prior summary level analysis that was presented a couple of years ago, suggesting increased mortality in patients receiving paclitaxel-coated balloons and eluting stents for FemPop disease. One of the challenges, however, was that there was up to 38% patients lost to follow-up at long-term follow-up, and it was not clear if there was actually a mortality signal. The last few years have been consumed by studies that have looked at this very carefully, and the preponderance of the evidence so far in large data sets, both randomized and population-based, have been that there is no mortality hazard, but there's been a number of limitations on the quality of these data. So in this setting, the Voyager trial was a over 6,000 patient trial, first reported last year around this time, looking at symptomatic lower extremity PAD with a 1-to-1 randomization of post-intervention treatment with either placebo or rivaroxaban 2.5 milligrams twice daily, in addition to aspirin, with long-term follow-up with very, very high compliance rates. And the primary endpoint of the study demonstrated that there was a reduction of a composite primary endpoint of major adverse limb events and perioperative death. The median follow-up was 31 months, and over 1,300 patients in this study received drug-coated devices, which is larger than any of the prior randomized data sets presented to date. A large number of these patients got drug-coated balloons, as you can see, and most of the patients had femoral popliteal intervention, with a significant number having infrapopliteal intervention. So the data presented by Dr. Hess was that there was no difference in an inverse probability weighted mortality hazard in these patients, comparing those who received drug-coated versus non-drug-coated devices. And again, the hazard ratio was 0.95 with the confidence intervals crossing unity. And this was, in summary, the largest randomized data set presented to date, even though patients weren't randomized to either a drug-eluting device or a non-drug-eluting device. The ascertainment of 99.6% of patients with vital status far exceeds that of any other data set to date, with very, very high quality long-term follow-up and CEC adjudicated outcomes where no associated mortality was identified with paclitaxel drug-coated devices. So, we would add to this important data set, the Voyager PAD data to supporting no mortality signal with drug-eluting devices. So very, very important. And there was a lot of discussion about this following this meeting. Following Dr. Hess's presentation, Andrew Holden from New Zealand presented the Philips Illuminate global registry data with their Stellarex drug-coated balloon for femoral popliteal disease. These were 4-year data. Again, this was a prospective registry of the Stellarex drug-coated balloon. Patients were followed for 5 years, and these are the 4-year data. And there was 100% source verification with core lab adjudication and a clinical events committee and a DSMB. The objective of the study was to assess safety and performance of the DCB in the femoral popliteal segment of patients up to Rutherford 4, which would be rest pain in lesions that are consistent with real-world treatment up to 20 centimeters and reference vessels 4 to 6 millimeters. The primary safety endpoints demonstrates an all-cause mortality of 8.1%, which is quite within the normal expected range for this patient population, with clinically driven TLR rates quite acceptable, also at 21.8% at 4 years. And there were no device or procedure-related mortalities. These are the data for clinically driven TLR. And as the authors concluded, this builds on the robust data for the paclitaxel Illuminate drug-coated balloon, which at 4 years has very comparable, I should say, safety and efficacy compared to the randomized control trials with no significant mortality excess that was observed. So that was the above knee segment, both with Voyager primarily above knee and Illuminate. Moving to below the knee, there has been a great deal of controversy as we have not seen the same kind of clinical efficacy with paclitaxel-coated devices below the knee. So Tony Mickery presented the IMPACT below knee RCT looking at 9-month primary outcomes, and this was the first presentation. This study was a small feasibility study in 9 sites in 5 countries with 50 patients to assess the safety and efficacy of IMPACT 014 drug-coated balloon compared to angioplasty in patients with complex lesions, including CTOs below the knee. These are mostly critical limb patients. Patients would have to have successful vessel pre-dilatation before randomization into either DCB or PTA. And there was strict protocol mandated follow-up with angiography at 9 months and long-term follow-up out to 3 years, which is certainly long in a critical limb population. Efficacy was measured by late lumen loss with angiography, and safety was a composite of major adverse limb events and perioperative mortality. Interestingly, these segments tend to be long, and so they were subsegmented into 10 regions so that there would not just be a binary restenosis, but rather a segmental restenosis. This will be important in a moment. The data at 9 months in these 50 subjects demonstrates a clinically significant, I would say, reduction in late lumen loss, about 0.5 millimeters in absolute value, which was not statistically significant when we use a binary late lumen loss comparison. However, obviously by multiplying the N by 10 using segments, there was a statistically significant late lumen loss. And this statistical approach received a great deal of attention in our post-meeting discussion about this study. Many would portray this as a negative randomized trial, albeit in a small subset. Others were more excited that there was a biological effect, seemingly, between below knee paclitaxel-coated balloon and PTA. And so the controversy continues. Again, the authors summarized that there was this difference and they acknowledged it, but also emphasized that there was a good deal of safety given the paclitaxel controversy that was ongoing, and there was a very low all-cause mortality over the course of the trial itself. So the conclusion was that this demonstrated feasibility and possibly clinical efficacy of a below-knee paclitaxel device. Finally, Aaron Armstrong from the University of Colorado also presented a study using a novel technique where periadventitial temsirolimus was injected in patients below the knee for treatment of critical limb ischemia. This is using the bullfrog device, which is a balloon that has a needle that can puncture into the periadventitial space and then allow for delivery of a payload of whatever compound. It's been studied previously with dexamethasone for inhibition of intimal hyperplasia and also with other kinds of anti-proliferatives, including paclitaxel and temsirolimus, which is the sirolimus analog. This was a 2-to-1 randomization of 2 different doses of temsirolimus versus saline control using a 6-month angiographic endpoint, which is something we'll review in a moment, called the transverse view area loss. And they had secondary endpoints looking at target lesion failure, including amputation and occlusion. What is this endpoint? Just like with the below-knee impact study, what these folks do in the core lab is they'll look at a long segment of disease and look at the net area of both the lumen and the intimal hyperplasia and create a view that basically is the sum of the post-revascularization lumen area, which is the sum of the area remaining at follow-up versus the area lost, and create a ratio of the area lost over this net area, which is a 2-dimensional measurement of volumetric intimal hyperplasia. And so it's an interesting approach. Here they show in all comers that there was a not statistically significant difference between the 2 treatment groups, temsirolimus having somewhat less intimal hyperplasia than the control group. When you exclude complex lesions, you see that there is certainly a statistically significant result. And again, this is a reanalysis of data that was done by the investigators and generated a good deal of controversy and discussion in the follow-up of the meeting. The authors concluded that they had identified an opportunity for adventitial drug delivery to demonstrate robust outcomes in this double-blinded phase 2 RCT, and that there was a, quote, sizable effect seen in more complex lesions, although again, not statistically significant in the absolute sense. So to summarize, at TCT Connect 2020, we had substantial emphasis on drug delivery. I think for above the knee, we can conclude that efficacy has been well established and the safety appears to be reestablished in follow-up of these data being presented at TCT Connect. The PMDA in Japan has actually withdrawn their warning about paclitaxel eluting products for peripheral intervention. Here in the United States, the FDA is still awaiting further data. On the other hand, in the below-knee segment, we still don't have great data that there is efficacy with paclitaxel-coated balloons, and we're still seeking alternate drug delivery technologies and drugs to perhaps improve outcomes in this segment. Thanks very much for your attention.
Thanks, Sahil. We have time probably for just one question. Marty, I'll give you the opportunity because if not, I have something to ask Sahil.
Sure, very quickly. I mean, this has been incredibly controversial, this issue of paclitaxel with drug-coated balloons. I was pretty impressed with the Voyager PAD data. Are clinical practitioners now beginning to realize that the early data on all-cause mortality probably was more of a statistical quirk than a biologic and clinical reality? And have they gone back to using paclitaxel DCB in a similar fashion to what had been done previously?
Yeah, Marty, it's absolutely what's been happening in the field. It appears that these data have been very reassuring to the clinical practitioner population here in the US and around the world. The use of drug-eluting products has certainly increased, and this has been heightened by the pandemic, where repeat revascularization and returns to the hospital have been particularly concerning to patients and providers. So I think there is a resurgence in interest in using drug-eluting technologies.
And a quick follow-up. It just seems that people are gravitating more towards sirolimus below the knee and are content with paclitaxel above the knee. Is that a correct perception? And is there any pharmacodynamic reason for that?
It's, again, a great observation. That is exactly spot on. The below knee paclitaxel data have been disappointing, even with this new data set where I think the strict interpretation is that there was not a statistical difference between the two groups. And so consequently, I think above the knee paclitaxel seems to be adequate, although I think it's set up for competition with other drug delivery technologies which are currently in clinical trials, including sirolimus agents. And then below the knee, it's wide open. And I think there is a hunger for new techniques. And again, whether or not temsirolimus is a demonstration of biological efficacy or not is in the eye of the beholder. But I do think sirolimus drug-coated balloons and stents for below the knee are in the offing. And the plausibility for this has really been seen in the use of coronary drug-eluting stents with limus-eluting platforms, which have demonstrated excellent short and long-term outcomes.
So
terrific.
I think we're going to have to move on. Marty, thanks. Great questions. Sahil, great talk. Reminds me a little bit of the DES firestorm from the ESC. It's like we seem to go in cycles a little bit.
Yeah.
So our next presentation from Ajay Kirtane will focus on the coronary science that was new at TCT Connect 2020.
Thanks so much. And Gary, that was a perfect segue. I think it really emphasizes the need for comprehensive long-term data with all of the outcomes measured so that if something happens like an untoward analysis, you can then sort of draw back on those data sets to reassure everybody, which is what's happened now. From the coronary side, we'll talk about several different topics. These are my conflicts relating to this talk and others. I'll start off with the diagnosis of chest pain because before we get to the cath lab, we have to figure out is the indication there to get to the cath lab in the first place. A very interesting study looking at FFRCT using the heart flow technology was called the Forecast study, and this was presented by Nick Curzon. It was a randomized trial looking at 1,400 patients, and they randomized patients to a strategy of somewhat conventional ischemic workup versus an FFR-based ischemic workup, with the idea being that could you reduce resource utilization at 9 months with an FFRCT-based approach? These are folks that had stable disease, de novo presentations for the most part, and then followed up through their testing. Interestingly, the study was a 1,400 patient study, but what happened during the time of the study in the UK, as many people know, is that NICE approved CT as sort of the go-to screening methodology for ischemic heart disease. And as a result, a fair number of patients in the reference group or the control arm actually underwent coronary CT. The difference between that arm and the test arm, though, was that if there was a stenosis greater than 40%, those patients would go on to get FFRCT analysis done, which would then potentially dictate their care afterwards. And we can appreciate that a large proportion of patients, as we see with coronary CT as a whole, demonstrate patients to not have any obstructive disease, and therefore they don't need any downstream testing. That having been said, for the patients that underwent FFRCT, about half of that group then went on to get coronary angiography. This is the results of what happened afterwards at 9 months. One can appreciate that there were less coronary angiograms done in the FFRCT group versus the reference group, which is a reduction of 14%. But on an absolute scale, there's not that great a difference in the number of angiograms done. And this, I believe, is largely because a large proportion of patients in the reference group actually got a coronary CT. If one were to compare this, for instance, to FFRCT versus nuclear, I think one might find a greater difference as seen. Because these differences were not that great between the testing strategies, one found that the total cardiac costs were not really different between both arms. In other words, the FFRCT-based approach, because it cost more upfront, did not save because it was only a small reduction in the angiograms that were done subsequently. And the clinical events were really largely similar between the two groups as well. So in conclusion, it was a negative study for FFRCT aiming to show a reduction in testing, but it does show that there potentially is viability for this approach, particularly if compared to more conventional strategies not including CT. Moving on to coronary calcification, it's a hot topic, and Disrupt CAD3 was a very important a non-randomized study presented at TCT, looking at the efficacy of the shockwave device, which, as shown in these OCT pictures, can affect calcium fracture, thereby facilitating stent expansion. In this study, patients were enrolled in an observational way with a roll-in period, as well as then what was determined to be an intent-to-treat population with 30-day follow-up in 381 patients. The vessels, by and large, were approximately 3 millimeters, but the calcified lesion length was almost 50 millimeters, with severe calcification by the core lab demonstrated in all patients. And overall, while the device could be used successfully, it did need to be pre-dilated. The lesions did in 55% of cases. But after that was done and the shockwave was administered with only a maximum inflation pressure of 6 atmospheres, one could see that stent delivery and post-stent dilatation was performed in almost every single case. The lumens got bigger progressively over time after IVL and then after the final stent implantation. And the rates of MACE were quite favorable, particularly considering that this is severe calcific disease with low rates of adverse events at the follow-up period. This study, after it got presented and published, ultimately led to the U.S. approval of this device, the coronary device, and therefore it's available for clinical use here in the United States. Moving on to stent studies, and we'll go through in a whirlwind because we have limited time. The key point of shorter duration DAPT is something we've seen a lot of studies doing in the more recent past. And there were 2 studies presented at TCT Connect, the Xience 90 and the Xience 28 data. And these are, again, observational studies looking at the safety of 3 and 1 month DAPT in high bleeding risk patients. The trial designs are shown here in schematic form, but essentially patients had a PCI if they tolerated their DAPT for up to 3 months or up to 1 month in each study respectively. They could then stop their DAPT, and then they were analyzed for the occurrence of adverse events. The average number of high bleeding risk criteria were 1.5 and 1.6, with up to 40% or more patients in each group being treated with chronic oral anticoagulation. And when one looked at the outcomes in these patients and compared it to a historical control from the Xience v. USA study, there were no differences in death or MI in either cohort of patients. And more importantly, I think for the clinician, was that the overall rates of stent thrombosis were very low in both this 90 cohort and also the 28 cohort, which I think gives reassurance to clinicians who have high bleeding risk patients that if they potentially have to stop early, that could be a safe thing to do in a carefully selected patient. Finally, one other stent study I'll show you is this Cobra Reduce study, which was a study aiming to determine if we could shorten the duration of dual antiplatelet therapy to only 2 weeks in patients treated with a specially coated bare metal stent, a polysine F coated bare metal stent. Patients were eligible for the study if they were on oral anticoagulation. And in this Cobra group, patients withdrew their DAPT at 2 weeks. In the control group, they received DES and they withdrew their DAPT later. The idea being that if you could withdraw your DAPT at 2 weeks, you would have less bleeding outcomes. And these were sort of the baseline demographics of the group. Unfortunately, the bleeding outcomes, while slightly lower, did not achieve statistical significance. So even though 2 weeks of DAPT was used, the DES arm did not have that greater rate of bleeding so as to differentiate between the two. And moreover, because the study stent was a bare metal stent, the rate of ischemic events was actually greater with that stent compared to the DES. So in summary, it did not meet superiority for reduction in bleeding and failed non-inferiority for similar outcomes in terms of ischemic events. The last trial I'll show you is the TCT Stemi trial, which was a randomized trial of ticagrelor monotherapy versus ticagrelor with aspirin, but in STEMI patients. The reason this is important is because in addition to making stents safer, if we can reduce the intensity of DAPT, we could perhaps impact bleeding in a favorable way for our patients. We know that the Twilight study looked at this in a larger series of patients, but what was unique about this study was that it was done in STEMI patients and the STEMI subgroup of the TCO study as a whole. So these took 1,000 STEMI patients and randomized them to taking aspirin plus ticagrelor for 3 months and then dropping the aspirin after the 3-month interval. The primary endpoint was actually MACE, a composite, but for the sake of time, I won't show the composite. I'll just show the components, which showed a reduction in major bleeding with this reduction in intensity of DAPT with ticagrelor. And similarly, the rate of ischemic events was not different between the two groups, which is why the composite was favorable for discontinuing aspirin after 3 months. Now, interestingly, they did present an analysis that looked at the overall risk of bleeding and also the risk of complex PCI. And what's seen in this analysis is that if you're a high bleeding risk patient, it really didn't matter what your strata was. It favored monotherapy with ticagrelor after 3 months. On the other hand, if you have a complex PCI, then this is where, although the interaction is negative, the point estimate starts favoring a longer duration of aspirin plus ticagrelor. Clearly, this is not powered to show that difference, but I think it does give a little bit of pause if you have a STEMI patient with a complex PCI in terms of when you stop your dual antiplatelet therapy. So I know that was a whirlwind summary of trials, but essentially TCT Connect aims to do that. We aim to feature all the best science that we can get our hands on. And for this year, especially when so many of us were starved for science because of the pandemic, it was a welcome change, and it's always good to refresh. So looking forward to the discussion, and thanks so much for allowing us to participate in this meeting.
Thanks, Ajay. Marty, I'll throw it to you first.
Great, Ajay, that was a beautiful summary, and some interesting topics. I think we all appreciate that calcified coronary disease in an aging global population is going to continue to be a big issue. And there's been a resurrection of atherectomy, and now IVL has become the new kid on the block. Disrupt CAD was certainly an interesting study, but to be perfectly honest, and we're trying to be a little controversial, it left me a little bit unfulfilled. It's a small study. It's less than 400 patients, carefully selected patients. Half the patients you had to put a balloon in to even get the device to the lesion to treat. And the outcomes, although reasonable, were not compared to anything else. So I don't know how well a non-compliant balloon or certainly atherectomy might have done in similar circumstances. And we're talking about an extremely costly device that now has approval based upon what to me is a fairly underpowered registry. Any comments on that?
Yeah, I would agree, Marty. I think that, the counter response would be that there are atherectomy devices that were approved with similar pathways. That having been said, the comparison to an NC balloon is a good one because we know for certain that NC balloons in a large proportion of patients may affect calcium fracture. I know Akiko and Gary and others have studied this, and it may be that for many of these patients, an NC balloon alone would have sufficed. But the bottom line is we need comparative data. It's one of the reasons why, finally with atherectomy, we're going to have a comparative study compared to balloon angioplasty. We don't know what that's going to show, but I think the similar studies need to be done with this device, particularly given the cost of the device, which, as you said, in the current environment is literally prohibitive here in the United States.
Yeah, I would encourage our Korean and Asian friends who may have access to this technology to start doing some comparative trials so that we have a better understanding. Two wrongs don't make a right. I think what was wrong about atherectomy in terms of not having good randomized data, is now being replicated. But in any event, second quick question is that I continue to be impressed that when it comes to HBR and short-term DAPT, that most of the current generation drug-eluting stents seem to be performing as well as you would expect from these more specialized drug-eluting devices. And it just seems to me, looking at Zion's 30 and 90 and then previous work with Resolute Onyx, that we should feel comforted that the current generation of drug-eluting stents probably are sufficient from the standpoint of short-term DAP and high bleeding risk patients. Is that your takeaway also?
Yeah, I agree. I think it's very reassuring. The only caveat, though, with data like this one, data from Evolve Short DAPT as well, is that there are carefully selected patient populations that go into these studies. And remember also that patients that have events in the first month during that period are not included in the analysis. So right. I think that those caveats are key. And for clinicians, it's not just that I can do 1 month of DAPT in every single patient of mine. It's you have to titrate the DAPT to the risk of the patient and think about every patient. And when you do the PCI, and think, what do you think is ideal for that patient? That's really the message I would take home from it.
And what percentage of high bleeding risk patients would you give a 1 month DAPT? Just a ballpark.
Typically I'm sort of approaching that with the specific stent type that was studied in that way, with, up to 50% or more, I'll sort of tell the referring that if we need to stop at a month, then that's fine for virtually everyone. And then at a month, I might start programmatically stopping in a large proportion of those patients.
Mm-hmm. Okay.
Great. So now let's move on to our third presentation from Akiko Maehara, and she's going to talk about the imaging and physiology science that was presented at TCT Connect 2020. Akiko?
Okay, so let me start from the prospect 2. So after the MI culprit treatment and 3-vessel neozyvus was performed, and if the non-culprit lesion having more than equal to 65 plaque burden, it was randomized either BBS or guideline-directed medical therapy. This is one of the case example. You have the culprit lesion distally and the proximal right coronary artery having the big lipid-rich plaque and big plaque burden and small lumen area. Patient coming back 3 years, you see the quite tight lesion now. So the overall event rate in the prospect 2 trial, non-culprit lesion-related event occur 8%, and culprit-related event occur 4.2%, which is much, much less compared to the prospect 1, which was presented almost 10 years ago. So the lipid-rich plaque was defined maximum LCBI more than equal to 325, which was upper quartile of the 3,500 non-culprit lesion. And if the patient having such lipid-rich plaque, they have about 2 times event compared to without. And if the lesion having such lipid-rich plaque, those lesions having about 7.5 times event compared to without. And if the lesion having both, which have much more event compared to without. And then this is a randomized subset. 182 lesion was randomized. And the primary endpoint was 25 months minimum lumen area measured by IVUS. At the baseline, both are similarly small lumen area. And BBS group BBS was implanted. At 25 months follow-up, even though there is some neointimal aplasia, we can see the big, large lumen area preserved compared to the medical treatment group. Although the event was not powered yet, we can see the very favorable outcome in the treatment cohort. So this prospect study confirmed the feasibility of this type of the concept. OCT can define the vulnerable plaques such as syncytial fibroadenoma, and the combined study answered that kind of question. This study, including all diabetes patients, and if the lesion having the FFR positive, it was treated, and it was not, and the blinded OCT was performed, and about 25% of the patient having the TICFR by OCT. The patient who had the TICFR, they have about 5 times event compared to without. And although this is patient-level data, but majority of the event is coming from the target lesion or MI, so that's more likely lesion-related event. So let's talk the physiology. So this is a defined flow. So the main question was this type of the patient. If the patient having the FFR positive, however, the coronary flow reserve were preserved, defined as CFR is more than equal to 2.0. If the patient having this type of the discordance, what's happening compared to the lesion which having the FFR and CFR was both preserved. So all patients having both measurement, and if the FFR was positive, and if the CFR was negative, defer the PCI. And this is how it looks like the discordance in terms of the FFR and CFR. The lesion having the FFR positive and CFR was negative is in 14% of the lesion. The outcome, if the lesion having the FFR positive, but FFR was negative, such as preserved, the coronary flow reserve, actually they have poor outcome compared to the lesion having both are preserved. So this study confirmed based on the target vessel failure as well. So the conclusion was those type of the coronary flow preserved lesion, but FFR was positive, actually not non-inferior compared to both are okay. So the next one is define PCI 1-year outcome. And this study already acute outcome was presented. after the PCI, post-PCI, IFR positive was found 25% of the patient. For those, 80% of the positive was due to the focal step-up. And this study, using the one-year data, what is the cutoff value most likely to differentiate those events without was less than 0.95. And if we divide those patients based on those cutoff value, we can see the clear trend in both two groups. However, this is very important. This study was based on their own outcome. Therefore, we have to confirm this type of the outcome based on the prospective manner, such as define GPS. And finally, target study. This is one step ahead compared to the defined PCI. So in this study, after the patient was treated by PCI and post-PCI FFR was performed, and then randomized to the control, which is not done anymore, or compared to the physiology guidance. If the post-FFR is less than 0.9, they are recommended to do additional treatment. So this is how they perform. If there is significant gradient still inside of the stent, or outside of the stent, if there is a focal step-up, they are recommended to treat. At the end of the procedure, including all patients, about 1/3 of the patients having the FFR positive. And for those, 39 patients was significant gradient inside of the stent, and focal step-up was found in the proximal segment in 7% and distal segment in 15%. And this is primary outcome. The patient who has final FFR is more than equal to 0.8, 0.9 is not statistically significant. However, in the physiology guidance group, based on the additional treatment, we can see the numerically higher, better FFR at the end of the procedure. So to summarize, based on the imaging study, we can see what is a plaque at risk and possible sealing treatment. And secondly, we found more and more data in terms of the post-PCI physiology and that's relationship with the clinical outcome. Thank you.
Thank you, Akiko. So Marty or Ajay, any questions for Akiko?
No,
Gary,
I think these are great. Go ahead, Marty.
No, I was going to throw it back to Gary. Gary, you're the imaging physiology person, so you should query your colleague.
Well, so we've been chasing this vulnerable plaque identification forever. And I think we can probably say that we know what a vulnerable plaque looks like, and we can probably say that we know it when we see it. But that, to me, still doesn't translate into a focal treatment paradigm, especially in today's world of good quality medical therapy, even forgetting PCSK9s. So the question that I'd ask Akiko is, when do we really start doing a therapeutic trial? When do we really start treating these? Because I look at Prospect Absorb and I sort of say, okay, but it's kind of like what you said, Marty, about IVL. It's like, okay, so what is it going to take? I mean, and especially if you look at the data from Prospect 2, which was the same as Prospect 1 and LRP, if you do 3-vessel imaging, you only identify 50% of the plaques that cause events. The others are in other parts of the coronary segment that are never imaged. So are these just great paper writing studies, or are these really clinically meaningful?
To me, at the end of almost 20 years, long trip, I do think this is clinically meaningful. And when can we do this type of study? I think very near future. But I think at the bottom line, what you said is perfectly correct. We really have to think about benefit and risk balance. Meaning, let's say Ajay, he is a professor and he's very important person in the Columbia University. And if he have the very vulnerable plaque in the proximal LAD, I very worry. And I would treat now instead of waiting 3 months. What do you think, Ajay?
Well, Well, I appreciate your concern, Akiko. That's great. But I think that the outcome studies need to be done. And some of the challenges moving from vulnerable plaque to the post-PCI physiology, for instance, is that in the UK study, for instance, trying to normalize the physiology, for instance, in an LAD, you can bang and bang and bang and bang away, and still the physiology is abnormal at the end of the case. So we really need to understand when's a good time to stop, because while I appreciate the concern of others and wanting to help me, there's sometimes when it may be better to just leave me alone and tell me to get in shape, exercise, and up my statins. So I think all of these things need to be sorted out, and hopefully the studies will be done to figure that out.
So Akiko, now based upon all of these interesting trials on physiology, when would you recommend post-PCI physiology assessment?
I would say always. But I think my take-home message is, instead of post, what is important is pre-PCI in terms of the pullback. Because if you start seeing the very diffuse disease in the pre, you may don't want to treat now because you know this is not normalized to the physiology. So I think a decision has to be made before start treating the bystand. And then post-PCI, I say always, because you engage to treat, so you have to be as better as possible. But we know LAD is impossible to go to the more than 0.95, so we may have to start thinking the different cut of each vessel.
I mean, I'm still, I still haven't seen anything, Marty, that gets me away from pre-intervention physiology to decide whether or not to treat, and post-intervention imaging to make sure we've done a good job. I mean, you can see individual patients, and you can look at huge numbers of patients showing slight differences, but that paradigm still seems to be holding. But at any rate, yeah. So it's time now for our last presentation. I'd like to now introduce Tamim Nazif, also from Columbia and CRF, who's going to round out the program by sharing with us data and trials and science in structural heart disease intervention. Tamim?
Hello, my name is Tamim Nazif, and I'm an interventional cardiologist at the Columbia University Structural Heart and Valve Center. I want to thank the organizers for the opportunity to present. I'll be discussing the late-breaking trials in clinical science related to structural heart valve interventions. These are my disclosures. TCT Connect was another exciting meeting in the structural heart space. We saw the presentation of important results of TAVR studies, including the primary results of the SCOPE 2 clinical trial, as well as updates from SCOPE 1 Solve-TAVI and the Partner 2 valve-in-valve registry. There were also important presentations regarding TAVR accessory devices, specifically cerebroembolic protection, and transcatheter mitral valve repair, specifically with regard to the MitraClip. I want to begin with the SCOPE trials. These trials are important, I think, in that they're emblematic of the type of study we're now starting to see in the TAVR arena, specifically studies comparing different available transcatheter heart valve platforms. In SCOPE 2, patients were randomized to undergo TAVR with either the self-expanding accurate neo valve or the self-expanding core valve Evolute. The primary endpoint was all-cause death or stroke at 1 year. And as presented by Dr. Tamburino, we see that in the intention to treat analysis, the accurate neo failed to achieve non-inferiority. As we delve a little more deeply into the individual endpoints, we see, interestingly, that patients treated with the accurate neo actually had significantly higher rates of cardiac death. And although we cannot definitively establish a causative link, it's interesting to note that those treated with the accurate neo also had significantly higher rates of paravalvular aortic regurgitation at both 30 days and 1 year after TAVR. We know that significant paravalvular regurgitation has been associated across multiple data sets with adverse late clinical outcomes. Now, one bright spot for the accurate neo platform was the significantly lower rate of pacemaker, right around 10%. And this has been seen across multiple studies now with the accurate neo. Rates of pacemaker and new left bundle branch block that are likely lower than seen with other self-expanding platforms. The results of scope 2 mirror to some extent those of scope 1. In scope 1, patients were randomized to receive either the Accurate Neo or the SAPIEN 3 balloon expandable valve. 30-day results were presented last year at TCT, and once again, the Accurate Neo did not achieve non-inferiority. And interestingly, again, had higher rates of paravalvular regurgitation, both at 30 days and 1 year. We should note that the valve gradients were in fact quite favorable with the Accurate Neo, significantly lower than the balloon expandable valve, both at 30 days and 1 year. When we look at the clinical outcomes, although we note the study was not powered for these endpoints, we see no difference in important clinical outcomes, including mortality and stroke at 1 year. So I think these results are promising for a first-generation valve and nicely set the stage for further study with the second-generation Accurate Neo valve that has an enhanced outer sealing skirt and other improvements designed to mitigate paravalvular regurgitation. So we look forward to additional trials with this valve. There was also an important update at this meeting from Solve-TAVI. I'll remind you this was a 2x2 factorial design, the early results of which were presented last year. Patients were randomized again to undergo TAVR with 2 different available platforms. In this case, CoreValve Evolute R or the Edwards SAPIEN 3, self-expanding versus balloon expandable. And they were also randomized with respect to the type of anesthesia, either local anesthesia or general anesthesia. And we see at 1 year, no significant differences in the composite endpoint or other important endpoints, including mortality or stroke, based on valve strategy and based on anesthesia strategy. So this is reassuring that our contemporary practice with both of these valve platforms and both of these anesthesia techniques, which are broadly used, are likely to be favorable and at the choice of the individual operators or centers. Final update in the TAVR trial space is from the Partner 2 valve-in-valve registry. We see 5-year data of patients who underwent valve-in-valve TAVR with the SAPIEN XT valve. To the right, I show the 5-year results in comparison to patients who underwent native TAVR in green inoperable patients and in yellow intermediate risk patients. And we see that although the patients in blue, valve-in-valve patients who were higher extreme risk, even though they were higher extreme risk, actually performed comparably, had similar survival to those intermediate risk patients from P2A. Also, it's notable that the hemodynamic performance of the valve in the valve-in-valve usage were quite favorable. We see gradients and total aortic regurgitation that were excellent and maintained from discharge or 30 days all the way out to 5 years. And there were very low rates of bioprosthetic valve failure, similar to those seen with native valve TAVR. And so this is reassuring that our current practice with valve-in-valve is comparable at least to native TAVR and can offer a good treatment option for our patients. I want to turn then to the accessory devices, specifically cerebral embolic protection. Dr. Jeff Moses presented the primary results of the REFLECT 3 clinical trial with the TriGuard 3 cerebral embolic protection device shown here. This is a new type of cerebral embolic protection that covers the entire aortic arch and the 3 main cerebral vessels. It's a self-expanding, self-positioning nitinol frame with a PEEK mesh. It's delivered from femoral access. It's 8 French and actually accommodates the diagnostic pigtail that's used for the TAVR procedure itself. So no additional access. This is the phase 2 of the trial shown to the right. This is done with the TriGuard 3 newer device, 2-to-1 randomization of protected versus standard of care TAVR. The device met its primary safety endpoint, which was a VARC2 safety composite based on historical performance goal. It did not, however, meet the primary efficacy endpoint, which was a hierarchical composite of all-cause mortality or stroke at 30 days, NIHSS worsening after the procedure, and cerebral ischemic lesion volume by DW MRI. These were compared by the Finkelstein-Schoenfeld methodology, and we see that the device did not achieve superiority with respect to this efficacy endpoint. And there's some clue perhaps to why this was the case when we look at device performance. Although successful deployment was very high, 100%, and it was successful on the first attempt at 98%, we see that technical success was only about 70%. And full coverage throughout the entire procedure, meaning prior to, during, and after the TAVR, was only achieved in about 60% of the patients. In a post hoc exploratory analysis, it was shown that above certain lesion thresholds, the device did seem to decrease the larger lesions on DW MRI. And this was enhanced in the bottom panel in the PT population. This is that patient population that did achieve complete cerebral protection throughout the entire procedure. And so I think this is hypothesis generating, but warrants further study with this device that if it remains stable in place, there may be signals towards efficacy. We also had an important update regarding the only approved device that we have here in the United States, the Sentinel device from Boston Scientific. The TVT registry analysis of the use of this device was presented by Dave Cohen, comparing patients that were treated with and without embolic protection. Interestingly, in this analysis, we see that while the number or percentage of hospitals offering embolic protection devices has increased steadily over time, it's still only about 30%. And the proportion of patients receiving embolic protection still remains very, very low, less than 15%. In the primary analysis, the instrumental variable analysis, we see no significant difference in outcomes in patients treated with or without the Sentinel embolic protection device. However, in a propensity-weighted analysis, there was a significant decrease in in-hospital stroke in patients treated with the embolic protection device, and there were significant decreases in in-hospital death or stroke and 30-day stroke or death. Again, I think this is promising and sets the stage for the results of the upcoming randomized trial, Protected TAVR. This is a large-scale trial currently enrolling in the United States, 3,000 patients with a 72-hour post-TAVR stroke endpoint. So a true stroke trial, the results of which are going to be, I think, anxiously awaited. And this current TVT analysis clearly shows the need and rationale for this trial. I want to conclude then by briefly sharing some of the results presented regarding MitraClip. This is data presented by Sahil Carr from the Global Expand study, real-world data on the use of the new MitraClip NTR and XTR systems. This new MitraClip has an enhanced delivery catheter that is easier to use and allows leaflet grasping separately on both sides. It also offers a second clip size, the XTR, with longer clip arms. This registry evaluated the real-world results, showed very nice reductions in MR severity as adjudicated by a core laboratory, mitral regurgitation less than or equal to 1+ in about 90% of the patients, and results that were durable between 30 days and 1 year, really quite favorable. The registry results also showed important and durable improvements in NYHA class and KCCQ score, a measure of quality of life. 1 year mortality and adverse events were favorable and similar to what was actually seen in COAPT, showing that the real-world usage of these devices does seem to mimic the favorable results seen in the most recent randomized trials. Again, promising data supporting further investigation and use of these devices. I'll conclude then with a brief mention of a small but very interesting trial called Mintz. This was a single-center, investigator-initiated study in which patients with persistent intraatrial septal defects that were iatrogenic after the MitraClip or other mitral procedure underwent either closure of the defect or conservative treatment. This is a question that clinically arises quite frequently, and we felt that it hasn't been necessary to close these defects in general, but there's been very little data to guide us. And this study was reassuring in this regard, with no difference in the primary endpoint of 6-minute walk distance at 5-month follow-up, whether the defects were closed or managed conservatively, and also no difference in clinical endpoints like mortality or rehospitalization. So I'll wrap it up there. I appreciate your attention. Again, TCT Connect 2020 was very exciting from the structural heart valve intervention perspective. We saw a number of new studies as well as late follow-up from previously presented studies that really, I think, serve to reassure us regarding the use of our contemporary devices and practices, probably more of iterative progress rather than foundational shifts in the field, but reassuring nevertheless with respect to our practice. I appreciate your attention and hope you enjoy the rest of the meeting. Thank you very much.
Thank you, Tamim. So, Marty, Tamim chose to focus on left-sided disease, but I know that you're particularly interested in tricuspid valve percutaneous intervention. So perhaps maybe we can round out the session with some of your thoughts about right-sided structural intervention.
Sure. Thank you, Gary. Clearly, I think Tamim summarized it very nicely that the changes this year are a little bit more iterative than transformational, which is really the state of the field when it comes to left-sided intervention. I think there are a few blockbuster trials that change treatment, and there are many new devices, both primary and accessory, that may continue to enhance some of the therapeutic successes we've had with aortic and now mitral disease. Tricuspid valve disease is a whole new area of development. It is so different in the disease presents itself late in its course from the standpoint of symptoms. Right-sided heart failure is a conundrum in terms of understanding both when to manage and how to manage. Surgery has been relatively ineffective and uncommonly applied to tricuspid disease. And there is no true guideline-directed medical therapy for tricuspid disease, severe TR, that induces a whole variety of downstream consequences, including hepatic congestion, coagulopathies, and hepatorenal syndrome. Then when you develop a diuretic unresponsiveness, it's very difficult to manage these very symptomatic patients. So the target has been TR, has a very high prevalence rate in the population, which is growing. And there are a variety of new therapies that have been developed, and now 3 pivotal randomized trials that have been started in the United States. The dominant therapies have approached leaflet grasping and valve replacement. So if you take the MitraClip and you saw the EXPAND trial of the new versions with the NTR and XTR, and they've made some adjustments in the delivery system. They now have one that is easier to use for tricuspids, and leaflet grasping has certainly become an entry technique for treating TR. And they've now begun a study called illuminate, which is an exciting randomized trial against medical therapy in patients with severe symptomatic TR. Parallel to that is another leaflet grasping technology, which is called Pascal. And they've also initiated a now randomized trial, it's called CLASP 2 TR, which uses the Pascal device. 2 different lengths, slightly different. It has a spacer and leaflet grasping capabilities with single arm capture as well. And it's now being applied in a randomized study in patients with severe TR. And finally, there's been very significant development with tricuspid valve replacement therapy. The largest series, which completed an over 100 patient early feasibility study, is using the EVOQUE valve, which is a self-expanding valve, which is introduced from the femoral artery with a very unique delivery system. After doing 100 patients, they are just beginning and are about to randomize their first patients in a pivotal clinical trial. So I strongly believe that there are going to be a host of new therapies to treat patients first who have severe symptomatic tricuspid regurgitation. And I think that's going to provide some therapy options that are currently not available in this patient cohort. And then later on, as I don't want to use the word preventative, but earlier treatment of TR will affect its natural history. And I can imagine once we understand the safety and application of these devices, that you may see more widespread use in less symptomatic, but still severe TR patient populations. So a lot of work being done, Gary, and certainly is an area of focus in many institutions in the United States now.
Thank you, Marty. So we're at the end of our hour. I'd like to thank my co-moderator, Marty Leon, as well as our speakers, Sahil Parikh, Ajay Kirtane, Akiko Maehara, and Tamim Nazif. And I'd like to invite everybody to TCT 2021. It'll be a hybrid meeting, both in person in Orlando, as well as virtual online. And it'll be the first weekend in November. And we look forward to a partial return to normalcy. Thank you very much.